So, good evening, everybody. We have this 30th episode of an online meeting, online presentation on behalf of ISA Ballari branch. So, good evening, everybody. We'll just check. I request all the participants to mute their episode of an online meeting, online presentation on behalf of ISA Ballari branch. So thank you very much for the patience. I request Dr. Srinivas to introduce today's speaker, Dr. Ravi Shankar.
Yeah. Good evening, all. It's my pleasure to introduce today's speaker, Dr. Ravi Shankar RB. He is a professor, presently professor at JJM Medical College. He did his undergraduation from prestigious KMC Hubli in 1984 and did his post-graduation from JJMMC Davangere in 1994. He has presented various lectures and during CMEs and conferences, and has been a postgraduate examiner in and out of our state. And he's scientific committee chairman in the well appreciated ISOCON Karnataka 2018 held at Davangere, and has organized many CMEs, workshops, and conferences. Thank you, sir, for accepting our invitation. Over to you, sir, Dr. Ravi Shankar.
Sir, it's not audible.
Fertilization in the laboratory with subsequent transfer of embryo back to the uterus. So what are the various steps? So preoperative evaluation, as we do, they do a thorough screening with a battery of tests, followed by ovarian stimulation by hormone. Normally in one menstrual cycle, only one follicle develops. But in this procedure, the ovaries are stimulated by hormones, HCGs, about 2 weeks prior and 36 hours prior, that is 1.5 days prior. Again, a trigger injection is given, following which multiple follicles develop in both the ovaries, as we can see in this figure. And this ovum pickup procedure is done under anesthesia. And this is the only painful procedure for which we anesthesiologists are called. This is followed by sperm processing by embryologists. And later fertilization is done by the embryologist, that is intracytoplasmic sperm injection. With the help of electron microscope, the embryologist injects the sperm into the cytoplasm of the ovum. So this causes fertilization, and this embryo is allowed to develop in suitable conditions of temperature, pH in the laboratory for about 2 to 3 days, following which the ripened embryos, the best quality embryos, are selected by the embryologist and the gynecologist implants the same to the uterus. This is the whole procedure. So this is the process as the figure shows. The first one is the ovarian stimulation. The second one is the ovum pickup under anesthesia, and of course sperm collection and processing. The third one is you can see the needle intracytoplasmic sperm injection, following which there will be fertilization and the embryo is allowed to form and develop for about 2 to 3 days, and then embryos are transferred back to the uterus. And the chemical pregnancy, which is so-called, is detected at 11th day by measuring the beta HCG levels. Clinical pregnancy is confirmed by ultrasound guidance and observation of gestational sac. So what is the role of anesthesiologist? Our role is to provide short duration anesthesia with speedy recovery for ovum pickup procedure without causing detrimental effects to the embryo. So preoperative evaluation, age factor. As we see in the Indian scenario, the couple comes only after 30 years onwards, 30, 32, 40, 42, even 45 years couples we have seen. And the oldest couple is 75 years, as we read in the recent newspapers. And as age advances, the comorbidities are likely, and these women may be obese because of sedentary lifestyle and faulty food habits. They may have PCOD, and there may be comorbidities like diabetes, hypertension, and we should rule out IHD also in an obese elderly woman. And they may be hypothyroid, as we are seeing a lot of hypothyroid patients nowadays on eltroxin. So we should take suitable care and titrate the anesthesia drugs in hypothyroid patients. Tuberculosis, common disease in India, which is the cause for the fallopian tube blocks. They may be on anti-tubercular drugs. We should know the interaction of anti-tubercular drugs. For example, streptomycin prolongs the non-depolarizing relaxant actions. Hormone stimulation, which is done by the gynecologist for development of follicles, can induce hypercoagulable status, for which there may be on aspirin or heparin, which have to be stopped prior to the surgery and optimize the coagulation profile. These couple are mentally depressed, and they may be on various antidepressant drugs like serotonin inhibitors, and we should know the interaction of them with our anesthesia drugs. So what are the techniques? In olden days, they used to do abdominal laparoscopic guided aspiration of follicles, for which regular general anesthesia involving either inhalation agents or relaxing technique used to be given. But the technique is obsolete now. Present day, ultrasound guided pervaginal aspiration of follicles is done with the help of the needle, which is shown with on the left side. It sucks the follicles, which are seen on the right side, and this is transferred through the plastic tubing to the test tubes, which are transferred to the embryologist across a small window, which the embryologist's room is just adjoining our operation theatre for observation and identification. So what are the anesthetic concerns? So scheduling this particular procedure, it's not in our control. We cannot dictate the timings and day. It's the embryologist who decides, because they are in short number. So they come from some other place, so they tell the timings and the date. So we get information 36 hours prior to the procedure. So our duty is to be available punctuality. Timing, we have to maintain the timings. We have to be very punctual. Otherwise, we should attend on time. Otherwise, the follicles might rupture and the whole thing becomes a waste. This is very important. We should keep a reminder in our phones, or best thing is to tell them to remind us the day before and on the day about 2 hours prior. And on the day of procedure, our duty is to allay the anxiety by giving buspirone tablets either earlier or midazolam in the pre-medication room. So these drugs, what we give, should not enter the follicular fluid, and they should not cause toxic effects on the fertilization or cleavage of the embryo. Our main duty is to give pain relief. So what are the causes for pain? It's the needle piercing the vaginal fornix and the ovarian capsule, which causes pain, for which we have to give anesthesia. So what is the ideal anesthesia? Since it's a short procedure and daycare anesthesia, what I said, our anesthesia should have a rapid onset and at the same time short duration, but we should have the ability to extend the anesthesia if the procedure extends. And we should provide optimum surgical condition, that is painless. Patient, it should be painless to the patient, and for the surgeon, the patient should be immobile, so that the needle piercing the multiple follicles should be facilitated by an immobile patient. If there is movement, it disturbs the aspiration, and the recovery should be prompt, and the patient should be street fit in another couple of hours. So there should not be any detrimental effects on embryo by what anesthesia drugs we are giving, and there should not be any post-operative sequelae like nausea or vomiting at the time of discharge. So what are the various techniques that are employed? Earlier, local paracervical block with monitored anesthesia care used to be given, and followed by general anesthesia, what I told, for abdominal laparoscopic procedures, either inhalation anesthesia or balance technique, followed by regional anesthesia, spinal and epidural have also been tried, and present at EVA, that is total intravenous anesthesia using propofol or ketofol combination or dexmed has been tried recently. Acupuncture is also one modality which has been tried. So regarding the survey, the conscious sedation or EVA is being practiced all over the world. So to define, it's a technique involving one or more drugs causing depression of central nervous system, at the same time facilitating the procedure, and patient should be arousable at the same time. So according to the survey, 84% of the cases are done by EVA in UK, 95% of the cases in USA, and 54% in Europe. So how will be the OT setup? This is a small OT in addition to the major OT in a gynecology hospital, or in exclusive IVF center, this may be the only OT, and we should insist on a minimum of boils apparatus. Workstation as such may not be all that necessary, but a boils is a bare minimum. And there should be facilities for intubation equipment, even though we may not be intubating the patient. There should be a multi-para monitor by which we can monitor the SpO2, heart rate, NIBP, and ECG. And of course, there should be things like working suction and emergency drugs. Ultrasound machine will also be there, and sometimes radiologists are called to help to show the follicles to the gynecologist. So this is a kind of non-operating anesthesia situation somewhat. So this is the picture shows the getting ready of various equipments by the gynecologist and the embryologist. Picture shows the embryologist in the adjoining room studying the follicular fluid under electron microscope. So after entering the operation theater, we should ask the surgeon how many follicles are there. There can be very few follicles like 2 or 3, and they are called poor responders, or there may be some 20 to 25 or even 30 follicles, so which are good responders. So accordingly, and whether the approach to the follicles is easy or difficult, that question also we should ask. So accordingly, we should plan the anesthesia technique. So what is the standard protocol practiced all over? It's TIVA, total intravenous anesthesia, that is involving propofol, fentanyl, midazolam, glycopyrrolate combination for very short procedures like poor responders I told, 5 minutes or even less. For procedures which are lasting for 15 to 20 minutes, an additional low dose ketamine can be added, that is 0.5 mg per kg, but not more than this. And there is another protocol called opioid-free anesthesia. And of course, monitoring, as I told, is by SpO2, heart rate, NIBP, and ECG is a minimum monitoring protocol. So what are the problems in this TIVA? So hypotension can be there. As I said, propofol can cause hypotension, but this is short-lived, transient, and self-limiting. But if it continues, it has to be controlled with vasopressors and intravenous bolus of intravenous fluids. Desaturation events are likely throughout the procedure, and from the beginning itself, this has to be managed with chin lift, triple maneuver, and if necessary, laryngeal mask airways or any other supraglottic airway devices. So tips to overcome the desaturation events is to pre-oxygenate well the patient 100% oxygen before inducing, and maintain the normal oxygen SpO2 with nasal oxygen devices. And by giving incremental diluted injections, we can prevent the desaturation events. I usually load fentanyl in 10 ml syringe with 10 mg per ml, and I give slow IV, and I take a 30 seconds break. Then I load midazolam 1 milligram per ml, and I give and take a 30-second break. Then I give boluses of propofol with intervals. So this would prevent the desaturation events. So this article of Indian General Anesthesia in 2009 suggests the above protocols. And there is this article suggests low dose ketamine in addition to remifentanil. Of course, we don't have, we are using fentanyl for oocyte retrieval. Coming to opioid-free anesthesia, this is a newer concept which is emerging to overcome the adverse effects of narcotics. So what are the adverse effects? First of all, fentanyl procuring is difficult. It requires excise license. It may not be there in all the centers. Second thing, addiction liability. Third, it's given in short frequent intervals, and it can cause pruritus, nausea, vomiting in the post-operative period, and the need for rescue analgesics either on the table or in the post-op period, and respiratory depression is also likely. So these are the side effects of narcotics. To overcome this concept of opioid-free anesthesia has come up. Here, what we give is dexmedetomidine, and one article suggests 0.5 mics per kg of dexmed in infusion 10 minutes prior to the procedure, and at the start of procedure, another 0.5 mics per kg infusion started, and if necessary, propofol is given in small increments. So this ensures a better hemodynamic status and better patient satisfaction and better post-op analgesia without causing any respiratory depression or vomiting. So this is the article which suggests dexmedetomidine for oocyte retrieval. So monitor anesthesia care with paracervical block is another practice which was practiced in earlier days. So there is limited experience of the anesthesiologists and gynecologists in the present day situation. And this is a blind procedure with uncertainty of action. And there is always a risk of intravascular injection. So this paracervical block is given in vaginal fornices at 4 points using 10 ml of 1% lignocaine. There is another recent block called pre-ovarian block, where with ultrasound guidance, they give 5 ml of lignocaine on each side into the vaginal skin and also to the ovarian capsule. Lastly, the acupuncture is another modality which has been tried. It involves multiple needle punctures on skin at various sites of the body. Once it was a popular technique practiced by Chinese, but now it's a fading specialty. It's based on the gate control theory of pain, which says it activates the endogenous opioids and increases the endorphin levels. Since the unpredictable results are there, it is obsolete now. So it cannot be practiced alone. It has to be combined with MAC, that is monitored anesthesia care. This picture shows the acupuncture needles on various sites of the body, so-called meridians. So what is the role of regional anesthesia? If GI is contraindicated for some reason, spinal or epidural can be tried. So regular spinal would be a long anesthesia for a short procedure. It's not advocated for a very brief daycare procedure. It requires admission and a half-a-day stay. So it's indicated where GI is contraindicated. Spinal, they have tried in low doses, 1.5 ml of bupivacaine with fentanyl will provide adequate anesthesia. There are articles where they recommend even very low dose of bupivacaine, that is 0.5 ml of bupivacaine with 10 mics of fentanyl. This provides an adequate anesthesia. Epidural anesthesia is of course also tried, but it is very time consuming. So this is an Oman Medical Journal which favors the use of spinal analgesia. General anesthesia with spontaneous or controlled ventilation is also tried, of course, with tube or with supraglottic airway devices. It involves giving nitrous oxide and inhalation agents. And nitrous no etomidate should be given because it impairs ovarian hormonal function. There are controversial opinions about this. Nitrous oxide, it inhibits methionine synthetase enzyme, which decreases availability of thymidine, which is required for DNA synthesis. But some articles says it's a very slow process, and hence this is controversial. Inhalation agents also, halothane decreases the fertility rate because of decreased perfusion, hence it's not used nowadays. Isoflurane in higher MAC for longer duration can affect, but sevoflurane, the compound effects, compound A effects in humans are very rare, and sevoflurane is advocated. So this article suggests the toxic effects of inhalation agents on in vitro fertilization. So one article says general anesthesia administering during oocyte retrieval may have adverse effects on fertilization potential of oocyte. Hence they don't advocate this. Coming to complications of this procedure, there can be bleeding due to needle puncturing the various follicles in both the ovaries, and surgeon might ask us to give tranexamic acid injection. Infection, of course, they control with antibiotics. Pain in the post-op period can be controlled with IV paracetamol or any other agents. Other than the IVF procedures, there are other procedures like fetal suppression. In India, by law, only up to 3 embryos can be transferred So if all the 3 embryo picked up and if there's a multiple pregnancy, one fetus can be suppressed according to the couple and the gynecologist opinion. And hence they do per abdomen ultrasound guided injection of potassium to the unwanted uterus. And we anesthesiologists will be called for the procedure, and we can give DIVA, that is Propofol, fentanyl, midazolam. To conclude, we the anesthesiologists have to become familiar with IVF techniques so as to plan suitable anesthesia to provide patient and surgeon satisfaction without causing deleterious effects on fertilization. The key to good outcome would be minimum exposure of anesthesia to the pickup procedure. I conclude my talk by saying, if an egg is broken by an outside force, life ends. If an egg is broken by an inside force, then life begins. Great things happen from inside. Thank you very much.
Thank you very much, sir.
Thank you, sir.
The last slide was most impressive one, apart from the whole presentation itself. Thank you very much for the nice topic which you suggested, and we are happy to have you today for the whole session. Of course, as you said, it is a recent trend that many of these small cases also have got these IVF facilities, and we as anesthesiologists are also called for our services. We can try to. So initially, anyway, I first apologize for some audio loss in the beginning. Somehow we are still not able to overcome the technical difficulties in online presentations in many of the platforms. And this presentation will be available in the YouTube also. The link will be shared with everybody. So we'll see that the audio mistake is also updated. Of course, it was only for the first 1 or 2 slides. So we'll take up some questions which are there in the chat box. And as we go forward, if people are, all the participants here can also raise their hands and ask questions, because it's a very important subject, especially not just for the practitioners, the postgraduates also, because the procedure is not done in many of the medical colleges. So it is better to understand the procedure by people who are doing it hands-on, like Dr. Ravi Shankar. So we'll just see. He has already answered. At the cost of repetition, there is no worry. I think Dr. Ravi Shankar will not mind. There's a question from Ramesh Kumar. Why can't we use fentanyl?
The fentanyl is one of the protocols, sir. That is the drug recommended in IVF because it's a short-acting synthetic drug. The only contraindication is where, if the patient is on selective serotonin reuptake inhibitors. Otherwise, majority of the cases we do use fentanyl, midazolam, and propofol, followed by propofol increment, sir. That is a usual protocol, sir, followed in most of the centers.
So,
which are employed in Belgaum and Bangalore also.
Everywhere.
Yes, sir.
So there is no major harm in the dose that we use in terms of fentanyl.
Yes, sir.
And we don't have remifentanil.
Yes, sir. Yes, sir.
So at this point of time. So maybe if it comes,
yes, sir.
it becomes easily available.
Yes, sir. In places where fentanyl is not there, I am using Fortwin, sir. But thing is, patient has to be kept for a little more time.
Longer time.
Yes, sir.
And you did talk about dexmedetomidine.
Yes, yes, sir.
You have been using dexmedetomidine, sir, regularly?
Yes, sir. Yes, sir. Not for this IVF, sir. For other cases, we are using.
You are using. Okay. So IVF, that's why I did not find articles where the dexmed use is it's not widely reported, at least at this point of time.
Yes,
because
sir.
Being an alpha agonist, we should also check for any evidence of hypotension.
Yes, sir. Yes, sir.
Possibly reducing the perfusion.
Yes, sir. Yes.
And affecting the risk of fertilization and other things. So that's one thing.
Yes, sir. Yes, sir. So that's infusion dose is quite less, sir. It's not the hypotensive technique like what we use. It's only 0.5 mg per kg, and infusion is started, but titrated to the effect. That's all, sir. For the max sedation.
So there is a very pertinent question from Dr. Vijayalakshmi.
Yes,
so
sir.
what tests are to be asked prior to this procedure
Sir,
in the background
the gynecologist would have done a battery of tests, sir. Almost all the tests, including hormonal, thyroid,
yeah,
sugar, all the tests they would have done, sir.
yeah,
Only thing, if they're 35, 40 plus, we can ask for a ECG and treadmill also, if
Yeah.
they're obese.
so
Just to
because
follow the ischemic changes, because I have seen many, even the doctors couples coming 40 plus with diabetes and IHD, and we should rule out subclinical ischemia.
yeah,
The resting
Sir,
ECG may be normal. Yes, sir.
Sorry to disturb, sir. These days we are giving spinal with chlorprocaine, sir.
Okay,
Because
okay,
it is short-acting
Okay.
spinal anesthesia,
okay.
so that procedure will be completed within half an hour. Because earlier we used to follow TIVA, but sometimes the gynecologists have the difficulty of
Okay.
puncturing the ovary because some patients will be having labored breathing, sir.
Yes,
So
yes,
the
sir.
ovary will be moving with each respirations.
Fine, sir.
So nowadays we are using spinal anesthesia with chlorprocaine.
Okay. So that's what, sir. In some of the articles which I showed, they have recommended a very low dose of bupivacaine with additive of fentanyl, 1.5, 1 ml, even 0.5 also. There is one article which suggests 0.5 ml of bupivacaine with 10 mg of fentanyl. So this would act for a very short period, just to facilitate puncture, sir. And that's
We have
also-
not used bupivacaine, sir. We are using chlorprocaine, sir.
That's also short acting, sir. And somehow chlorprocaine is not very popular here. This company person had come. Okay, sir. That's one option, sir. And regarding movement in what you said, sir, respiration disturbing the follicular aspiration. So earlier I used to give this propofol, fentanyl, midazolam, and if it is not adequate, this addition of a low dose of ketamine helped, sir. And frequent boluses of propofol, 20 milligrams, that would deepen the anesthesia, preventing the too much of movements.
Yes, sir.
And spinal is another good option, sir, like what you told. But only thing, we have to keep them for at least half a day before we make them walk on a straight line and then make them street fit.
Because chlorprocaine is very short acting, no, sir.
They would
In
come
45 minutes, 1 hour, patient will be moving the limbs and able to walk.
That would be very good, sir.
yeah.
Yeah.
So in fact, because our PGs are participating now, when
Yes,
you
sir.
talk about the preoperative workup, as you say, there is always a risk of comorbidities, as is usual, but it is more likely in this group, as you said, because they are elderly people, sometimes, and they are on hormonal therapy already.
Yes, sir.
Yeah, so hypothyroidism is many of the times a frequent accompaniment. So the thyroid status and the thyroid replacement that the patient could be on, then recent thyroid function tests, then the hormones, hormone levels also, as I said, they would have done already.
Yes, sir.
And ovarian hyperstimulation in some patients would have been detected early. So it has got its own implications. So those things also we have to keep in mind. And one thing probably theoretically, I don't know, sir, whether your centers had also included patients where there is some genetic predisposition and known genetic problems in a previous attempt, previous normal conception or IVF per se. If they had some problem where genetic problem is detected either in the father or the mother or due to some reason, so they will also be subjected to IVF procedure.
Okay, sir.
So the whatever is fertilized, that's also then subjected to further investigations to check for any implantation problems, other things which are all under the domain of embryology. So those patients will have some additional risks because of presence of some genetic disorders.
Yes,
I
sir.
think these are some of the patients which are suitable to go to higher centers where workup is further required. So otherwise, as you say, we have to follow up on the patient and advise accordingly the preoperative period.
Sir, yes, sir. Sir, Valvaskar, sir, in that case, if there is a history of genetic, history is there in previous conceptions and all, then the anesthesia suitable option would be spinal, sir, low dose spinal, because most of these GA drugs, they are all lipid soluble and they enter the follicular fluid. And at a later date, if the baby is, abnormal, they may blame the anesthesia.
Yeah.
So then we can jolly well say we have given spinal and nothing else. No
Yeah.
sedation, nothing else we have given.
Yeah.
So we can say that. And the spinal won't, this BPVCAN won't enter the follicular fluid at all. We can say. So I think that would be a better option, sir. Low dose spinal in such patients with genetic history.
Okay.
Is it, sir? But I have not come across, sir, so far.
Yeah, sir. They are supposed to be additional patients, a separate set of patients.
Yes, sir. Yes, sir.
To be encountered.
Likely.
Yeah. So Dr. Sheetal Desai is suggesting sometimes gynecologists need push for ovary per abdominally.
Yes,
and
sir.
keep muscle relaxation.
Sir, that is why these radiologists are called, sir. In one of the centers where I go, the radiologist is called and he will do perabdominal manipulation to make the follicles superficial and accessible to the needle, sir. So in that case, the patient might become light. So our duty is to give increments of propofol, sir.
Yeah. So there will be correct localization.
Yes, sir.
For the needle to reach.
Yes, sir. Yes, sir.
That will be better in those patients.
Yes, sir. Some centers they do routinely call radiologists.
Okay. Then we have Kiran Chand has asked whether we have to preload because we don't want hypotension with propofol.
Yes, sir. Yes, sir. So routinely we are not giving any intravenous fluid, sir, but a maintenance fluid would be okay. Anyway, we are monitoring the blood pressure. The hypotension to propofol is very transient and self-limiting.
Okay.
Okay. Unlike spinal, sir, we don't either preload or co-load the patient. Unlike spinal, but a maintenance fluid would be okay, sir.
Okay. So Dr. Rahul has asked a question which is already answered. What procedures, spinal anesthesia or regional or just local with TIVA? So I think sir has given all the answers in the slide. So
Yes,
most commonly it is the sedative based technique with propofol and fentanyl and midazolam or dexmedetomidine. TIVA is definitely the perfect TIVA can also be in place. There is no problem. We can use an infusion based upon the TIVA principle that can be done. There is no issue at all. Dr. Yogendra, ideally a small procedure. Yes, we know all of it. It lasts for about 15 to 30 minutes, sir, normally.
Sir, 10-15 minutes only, sir, depending
That's
upon
all.
the surgeon.
Yeah.
10-15 minutes only, sir. It can be short. If they say there are only 2-3 follicles, it may be only 2-3 minutes. But the longest one is around 20-25 minutes, sir. The procedure is called long if it is more than 30 minutes and if there are 30 follicles.
Okay.
But usually they don't take, sir, if there are 30 follicles because there would be, that hyperstimulation syndrome features will be there.
Yeah. So in fact, I don't know, Dr. Yogendra, if you are online, you can also speak. What he has asked is, what would be the minimum mandatory test for medico-legal purposes, sir? I am not able to understand his question. You are online, Dr. Yogendra?
The routine our pre-screening, sir, more than what we need, they would have done, sir.
Yeah.
Like thyroid, CBC, sugar, creatinine, all the drugs.
They are all based on Government of India guidelines nowadays.
Yes, yes, sir.
Very strict guidelines from the Government of India.
Yes, sir.
Definitely all our obstetrician colleagues and fertility specialists are subjecting the patient to all the
Yes, sir. Yes, sir.
tests.
ECG, sir, that we should insist if it's an elderly for a woman, ECG, all the more if they are hypertensive diabetic and if the history is there, then we have to ask for ECG.
Okay. Dr. Deepak has suggested we can use nalbuphine if fentanyl is not available for good analgesia.
Okay.
It's available. Nalbuphine was available. I think if it's all a matter of your convenience, whichever drug you are used to.
Yes, sir. Yes,
always remember that the fentanyl currently in India is better for us if available because of recovery characteristics being good. Otherwise, as sir is telling, even pentazocine sir is using that there is no harm. It's only a matter of managing intra-procedure and in the post-operative period, probably longer duration of inpatient stay would be required.
Yes, sir. Yes, sir.
And Dr. Krishna has asked pentazocine with promethazine.
Sir, promethazine will cause a longer lasting sedation, sir. It's a very good antiemetic sedative, but it's a very longer lasting sedation, sir. So
Yeah.
they will be confined to the post-op for quite hours.
Yeah.
Usually the whole stay of the the donor, I mean the woman, either the woman of the couple, or sometimes donors are there, sir. They come from some other place, and hardly for a total duration of 3 hours, half an hour prayer and 20 minutes procedure, maybe another 1 or 2 hours post-op, and then they'll be discharged, sir. But if we give things like Finargan, their stay will be lengthened.
Okay.
All the more the donor might not like to stay for a longer time. So, for example, for Davangere, a donor will come from Bombay, sir.
Yeah.
They have to stay overnight. So that would donor may not like to stay in the hospital for a longer time.
Plus, again, probably my point of view is you should be comfortable with the pharmacokinetics of the drug. You should know for a patient what should be given.
Yes, sir.
Because it's a matter of a synergistic effect. When you combine these two drugs, generally it is synergism. For example, we used to give 25 milligrams of bethadine, or for example, 15 milligrams of pentazocine, plus combined with Phenergon. Again, half dose. So those are the practice. But only if you are used to using these drugs correctly, I think you can go ahead. Otherwise, there are a lot of disadvantages.
Yes, sir. Yes, sir.
Yeah. And Dr. Sheetal Desai, who had asked about the muscle relaxation, she has said that she has used supraglottic airway wherever muscle relaxation was required with controlled ventilation whenever pickup was difficult.
So, but again, to blunt the awareness, we will have to give inhalation agents. So, along with relaxants.
Yeah.
So, the use of inhalation agents, if you go on studying the literature, it's quite controversial and conflicting.
Yeah.
But overall consensus is not to use nitrous oxide and this inhalation agents, sir.
Yeah.
So, if you can put in a supraglottic device, but maintain with propofol only.
Yeah. So overall,
fentanyl like that only.
Yeah. Dr. Rahul, you want to speak? You have raised a hand. You can introduce yourself and speak. I don't know.
I think to mute. No. Yes, to mute.
Yes, to
unmute.
Unmute. He is muted, sir.
You are there, Dr. Rahul?
Dr. Rahul?
Okay. So anyway, as other people have suggested, we also spoke about, for example, using chlorprocaine.
Yes, sir.
So avoid all the complications of general anesthesia. Just stick on to chlorprocaine, or
Yes.
you said low dose of bupivacaine with the fentanyl 10 mics. That will be more safer than giving, and more convenient than giving, for example, a full dose of relaxant and giving controlled ventilation to the patient, even with LMA.
Yes, sir.
Sir, Subramaniam sir, is chlorprocaine available in your area, sir? Because it's not available with us. It was available almost 1 year back, but it's not available. Actually, I was using it for short orthopedic procedures. It was working well, but it's not available in our area. If it is available, I think it will be good for even outpatient.
I think it's reintroduced now.
Yeah. It was available last year. Since almost 1 year, it's not available.
So they said they will reintroduce. Probably
Yeah, they will.
reintroduce in Anantapur.
Yeah.
Yet to be reintroduced in Ballari.
Yeah, maybe.
So, Dr. Kanav has asked our guide regarding the dose of chlorprocaine in oocyte retrieval. They are not used, but can you give I think the same dose which you use in lower limb surgeries, Dr. Srinivas, same dose can be used here.
Yeah. I think 40 mg.
Yeah. So Dr. Rahul is telling about the medico-legal issue per se.
Yeah.
In terms of what should be a pre-operative investigation. We can have multiple approaches. What the literature says. What the literature says is basically that also, because I have also gone through the literature before this program. So as anesthesiologists, we must go through the usual battery of what is recommended for this procedure. So as anesthesia, from anesthesia point of view, this becomes not a major procedure, it's a minor procedure. But it is left to your individual discretion when you discuss with the obstetrician, the fertility specialist, and when you think about the implications related to general anesthesia, what are the problems with respect to the success of the IVF and with the success of a viable pregnancy and a viable birth. So these are important outcomes. So keeping these things in mind, we can always go through the investigations and look for the comorbidities. As sir was telling, many of the patients are now aged patients. There could be diabetes, there could be hormone-induced changes in these patients. Ischemic heart disease is also seen in majority of the patients. So please do a workup based upon your assessment of the patient. So what the court say is what is minimum, and if you ask more, court doesn't interfere. Court will only ask why you have done additional investigation. So this is what is the stand of ISA also, because we had introduced the preoperative guidelines about preoperative investigation. Pre-op investigation. So we can only suggest the minimum mandatory testing. But if you don't want to advise further or advise further, both of them is left to your discretion only. The court can only ask you why you have not done. You can justify that you have not done because of these reasons, and you have done because of these reasons. So that is the importance of justification. So as luckily sir is telling, I have also gone through many of the records of these patients. More than required investigations are already done.
Yes,
because the obstetrician is
Hello.
basically scared about the current day consumer forum disputes and all. Majority of the investigations are done.
Sir, actually, sir, one point.
Yeah.
Sir, actually, in the consumer courts, what I have attended, first
Yeah.
thing they will ask is whether the thing procedure what you have done is right or not wrong. Only that thing they will ask.
Yeah.
That variety of things they don't bother, sir. If it is done, that procedure is right, they'll accept the things.
Okay, because you asked about about investigations per se, or you asked about the whole management? Only the investigations. Okay, so what we can also infer from Dr. Raul's opinion is probably he is meaning that we have to follow a standard, widely accepted protocol in terms of pre-op investigation and the intra-op management of the patient also. So that is definitely accepted. And as experienced anesthesiologists, we can always comment that safe practice is always the best one. So whoever is starting the practice afresh, so please stick to the basics. Don't hurry in terms of accepting the procedure. Do a thorough pre-anesthetic evaluation. So as sir is telling, there is some time limitation. About 1.5 days is given. And because the donor has to come, and normally it is an outpatient procedure, somebody has to come from other small places also. If it is Davangere, if it is a big place like Bangalore or Mumbai, people would come from district headquarters. So the time factor, economic considerations are also there. So there are some things which we have to adjust to, but never put your practice at risk and indirectly the patient's life at risk. So that much I think I can say. Then put LMB and manage. There is a suggestion from Dr. Kosnis. Spinal is next best option, but bladder evacuation should be taken care of. So that's also an acceptable outcome. When you want a patient to be discharged early, so we don't want, of course, too many opioids to be given, too much of general anesthesia to be given, and a longer acting spinal anesthetic to be given. So if you have got Prilocaine and you are happy to use Prilocaine with good experience, that's also an option.
Yes, sir. Yes.
Yes, then IGL is good. Aditi Kasnis has commented that she has done it. And Dr. Mukesh, I am giving oocyte retrieval anesthesia for 20 years. He said, I am using fentanyl, midazolam, and propofol with oxygen inhalation. And most of the time it is sufficient. I think the same experience with Dr. Ravi Shankar.
Yes, yes, sir. That most of the places that is the standard protocol, sir, which I inquired.
Yeah, okay. Can we use lower dose of isobaric levobupivacaine, ropivacaine?
Isobaric, our experience in spinal is very limited, sir. And we can't try these in these kind of cases. Yeah, once we become, like experienced in our other routine cases, then we may, if we are convinced, then we can adopt to this. But these people are, normal patients. They are not like, high risk cardiac patients, not like that with low ejection fraction and all like that. So it's not, we can use a hyperbaric only. So isobaric may not be all that necessary.
Okay.
Control will be better with hyperbaric.
Yes, sir. It's a sure shot, confirmed and standard technique. So these isobaric and all, they are coming up now. Same thing like segmental, spinal, or epidural. They are all of late coming, but still they have not entered the textbooks also, sir. To quote.
Yeah, we have to acquire a skill in managing using those techniques also.
Yes,
sir. Regarding chlorprocaine, actually, to attain a level of T10, it is 50 milligram. For this lower limb surgeries and all, usually 30 to 35 milligram will be used. That will come to it is available in 5 ml ampoule. I think 10 milligram per ml. Yeah,
duration, sir, how long it comes?
No, by usually by 20 to 30 minutes, patient will be moving the limbs by 30 minutes. Yeah,
okay,
especially motor recovery will be faster with that. Actually, it was suggested for outpatient anesthesia, where regional role of regional in outpatient anesthesia. This chlorprocaine has been discussed.
Okay.
Dr. Niranjan has asked, sir, can I use tranexamic acid for post-procedure oozing when follicles are many?
Yes, sir. It's routinely indicated. If the follicles are multiple and if there is bleeding, surgeon will definitely ask, or we can also give tranexamic acid. That's a routine, sir.
Routine one nowadays.
Yes.
Dr. Jagdish Hegde, you want to...
Extreme cases, sir, like what I read in the literature, extremely rare cases, there can be considerable bleeding. Then what they do is they do a perabdominal laparoscopic aspiration of the blood in the pouch of Douglas, and then they cauterize the ovary, surfaces of the ovary, they cauterize. Like what they do drilling in the routine laparoscopy, they cauterize the bleeding points in the ovary of both the sides by doing a laparoscopic approach, and then we may have to convert the anesthesia. But that is extremely rare, sir. That's like I read in the literature only.
So probably literature would report all extremes also.
Something. That's
Something.
Sir, if 30 follicles are there, they won't take up. So ideally it's about 15 to 20.
That much.
Yes, sir.
Dr. Jagdish Hegde, you are online.
Jagdish Hegde.
Can unmute and speak.
May I? Yes, written.
Hello.
Yes,
sir. Yes, sir.
Good evening, sir.
Good evening, sir.
There are two things. My little experience with this Ropucaine. Actually, 2 years back, we did company-sponsored study also, isobaric, and making it hyperbaric by adding soda bicarb. What we found was it is good with where you need sensory loss. Wherever you need muscle relaxation also, it is not much useful compared to bupropion.
Correct, sir.
And the second thing is, have you seen any allergic reaction to tranexamic acid, sir?
Anaphylactic reaction, sir?
Yeah.
No, sir.
Because last 2 months back, one of the famous Bengaluru oncosurgeon had hemorrhoidectomy. And he only preferred tranexamic acid. As soon as we give tranexamic acid, is almost near arrest.
Pardon,
and
sir?
we manage
near arrest. He says near arrest.
Oh, okay. Following tranexamic acid.
Yeah.
One recommendation is that it should not be given fast. It should be given pretty slowly.
Because usually we give 1 cc first, then we usually add to this IV fluids.
Okay, sir.
No, it's a rare experience. I don't know.
We have not come across any anaphylaxis, sir. It's like in gynecology, it's a routine practice, sir. Most obstetrician and gynecologists, they only ask us to give tranexamic acid at the end.
Used, very widely.
Isn't it, sir?
Because,
very widely used, and I have not come across.
Yeah, because of late I'm practicing this IVF also.
Hmm.
In most of the centers, the facilities are very minimum.
Yes, sir.
So, while giving this tranexamic acid, after that experience, I'm little bit hesitating.
We should have emergency drugs, sir. That's what I said. All the emergency drugs to
That's
tackle
what
the.
we managed. That's it.
So that's
Like
what when Dr. Rahul asked about medical legal implications, all the onus is on the anesthesiologist only.
Yes, sir. Yes.
We comment about probably minimal facilities. The intervention also has to be minimal. Okay, if I say I want to give relaxant, I want to give controlled ventilation, yes, you can give. Because there are some pros and cons about the sustenance, whether fertilization indeed occurs, whether it becomes successful and all. They are all data are there. But first of all, we should be able to give balanced anesthesia, see that the patient recovers and she is also shifted out safely. And setup is similarly available.
Yes,
we have got all the monitors and everything. So this basically the sedation using propofol and fentanyl has stood the test of time. Basically,
yes, sir.
So when you talk about tranexamic acid, it's very unfortunate that there has been an event. But as you say, it is used across the fields nowadays. The trauma, the orthopedics, the obstetric practice, and everywhere it is used left, right, and center. But it's a cause of concern when you hear that there is a risk of some anaphylaxis. So ultimately, I think we should always, the dictum for anesthesiologists is try to administer as an infusion.
Yes, sir.
Don't push it fast and IV, because bolus effect is always there for any of the drugs.
Yes, sir.
Whatever. So it's advisable to do that and avoid bolus dose and give as a slow infusion. At least in a 100 ml saline, you can push it.
Yes, sir.
So that's advisable. There is a question from Dr. Savita. What about fluid management immediate post-op in OHSS patients?
Sir, usually no fluid is given, sir. OHS means ovarian hyperstimulation syndrome.
Yeah.
So usually no fluid is given, sir, post-op. It's only the maintenance fluid, that's all.
This OHS is also, I think, fully overt, blown out.
No, sir. They won't take such patients. They won't take such patients.
They won't take.
Yeah. They will stop the hormones. They will allow the patient to settle down.
Yeah.
They will take at a later date. Sir.
That's all.
Yes, sir.
We've got very good management and assessment nowadays.
Yes, sir.
It's purely of academic interest. They are not taken up at all.
Yes, sir. Yes, sir.
Yeah. The next choice better, Dr. Niranjan. Always IV test dose. Test dose for everything.
Yes, sir. Yes, sir.
That's always there. Right.
But we should, for any drug for that matter, sir, even most surgeons ask us to give antibiotic on the table just before surgery. And the incidence of anaphylaxis is about 1 in 10,000, even for any antibiotic for that matter. So we should keep adrenaline, hydrocortisone, all these emergency drugs, sir, to manage deriphyllin, whatever. So anaphylaxis can occur to any of the drugs, sir.
And what I only feel is, with respect to the various questions related to anesthesia, only problem with GA or trying to give more drugs is what I found in the literature is the rate of fertilization is little bit less.
Yes, sir. Yes, sir.
Okay, but subsequent, once fertilization takes up, the subsequent stages, there is not much difference between not giving anesthesia at all or giving a full-blown anesthesia. A fertilization is the one which could be slightly less in patients where a typical GA is given.
Yes, sir.
But a standard propofol with other drugs which you are using and the GA post-fertilization, I think the instance of all the outcomes are similar.
Yes, sir. Yes, sir.
But very strangely, normally we talk about the propofol being getting accumulated in the follicular fluid, precipitate and plus hypotension due to propofol and other things. I don't know, but I couldn't understand. The literature has given that there is a ceiling effect.
Yes, sir. Yes, sir. Correct, sir.
Beyond that, the dose doesn't have effect. It is not dose dependent.
Yes.
Any idea about sir? Any further material about that, sir?
Sir, that's what they say. You should not give propofol for a very longer time. In larger doses, and definitely they have found decreased fertility rates with a longer period of exposure of propofol because it readily enters the follicular fluid. So in that case, what sir will like fentanyl is safe, midazolam is okay. So other two drugs we can try combination. After like for example, I have given up to 3 vials of propofol, and then I'll stop at that level, and if further required, I'll add fentanyl and midazolam.
Okay. And very unusually, as you say, you can push in a little bit of ketamine.
Yes, low dose ketamine, sir.
Yeah.
That would be very nice, sir. I'm very comfortable with that.
Yeah.
Just 20
Multimodal.
to 25 milligrams of ketamine, that's all.
Multimodal rather than sticking to.
Yes, sir. Aram sir, we can do 15 to 20 minutes the procedure, sir.
Okay. So we had a lot of questions. Any questions further from our participants today? Any questions for postgraduates?
Like those who have given anesthesia in this kind of setup, sir, if they have come across problems, then they will interact.
Yeah.
They will question, no, sir.
It is limited.
Any question definitely PG should understand.
Yes, sir.
There was very nice input from our practitioners and consultants in today's program. So I'm thankful to them. No other questions?
So in the years to come, many anesthetists will be called for to give anesthesia in this IVF setup, sir. So a knowledge of how it looks like and what we should do, we should know, sir. Like the very first one, when I went, the gynecologist, he gave a printout after coming from his fellowship. Sir, please go through this and follow only this procedure. That's what he said, sir. And it contained this much only. Propofol, fentanyl, midazolam, like that. So please don't deviate from these norms, he said, sir.
So it's an encouraging thing for anesthesiologists.
Yes, sir.
Because we have been talking about the future of anesthesiologists. So it's a paradox. Fertility issues are becoming more and more. IVFs get more and more, and anesthesiologists would have more scope.
Yes, sir.
Okay. So if there are no more questions, I think I will end the session. Dr. Parimala, you are there on duty? Okay, our secretary could not attend today. President was there, but she is stuck in hospital. Okay, so
sir,
yes,
Balabhat, Dr. Allegation here.
Yeah, please.
I have a view about this IVF because I do extremely different way than what was said now. It is all similar only. Pre-anesthesia, we do clotting profile for all the patients, irrespective of who they are. Because there are some incidents where there were mortality because of bleeding, which was not seen, and patient died later on in different hospitals all over India. And the only reason was clotting tests were not done.
Okay.
So we make it a point for all the patients, we do a clotting test, all clotting profile.
Okay.
So that we know if there is any issue before starting the case. So that we have changed in practice because of few issues all around India. We had this bleeding issue post-op, which was not recognized because these are all daycare centers where the anesthetist will give and go off. And the patient is not monitored. By the time you catch the patient, it's too late.
Yes, sir.
So one
coagulation profile they will do, sir. All the more if they are on anticoagulants, they'll stop, they do coagulation profile, they optimize, and then only they'll take.
So this is mandatory we have made in the past 6 months now. And then intra-op, what we do is, I do, for all the patient, I give a supraglottic airway. And I do give them a small dose of a relaxant, keep them completely ventilated. And I give them inhalational agent, that sevoflurane. And oxygen air sevoflurane. propofol, fentanyl, midaz, glycopyrrolate, small dose of atracurium, and then at the end of the procedure, we reverse them. So that I don't want the patient to be having that labored breathing, what it was said before. And though it is a small procedure, I think more comfortable in maintaining the airway with a supraglottic airway is better than struggling in between when patient develops some sort of bronchospasm, laryngospasm, whatever it is. So I generally do with the supraglottic airway and with a relaxant, very small dose of relaxant, and then reverse the patient at the end of the procedure. And I was using this Teva propofol before, but I stopped it because we had an incident in Chandigarh that the patient died because of query propofol or not, we didn't know, because of the Teva procedure. So from then on, I stopped this Teva propofol. So I'm continuing still with just the sevoflurane, oxygen air, and LMA. So this is what I'm doing. And I'm not, I generally not keep the patient spontaneous for my patients. So I don't, this is my practice, but I don't know how it will help.
That's a very good input, sir. Fine. Particularly where, airway is, it's very difficult to manage the airway. That's a good option.
Because most of the times at the end of the procedure, we have some patients who go for bronchospasm or laryngospasm, so difficult to manage at that time.
Yes,
generally,
right.
we don't have good technicians in this sort of setup. They're all very small setups where we don't have a proper trained technician. So
yes, sir. Yes, sir.
I do this as a routine nowadays. I've stopped doing this spontaneous thing. So I just
That's a very good input,
make
sir.
a point.
So only thing, we will have to keep them in the post-op for a comfortable,
Post-op.
1 or 2 hours. And
Yeah, they because it's sevoflurane, they come out very quickly, and it's
yes.
just
Even
a matter of
atracurium
few
also,
minutes.
the prompt recovery of relaxant.
Yeah, it's very quick.
Very prompt.
I just give 10 or 15 milligrams.
Yes,
I
yes.
don't give more than that.
Yes,
So
sir. Even reversal is not a
depending
must,
on
they
the
say.
yes, so this is what I practice, because we found some patients with obesity and hyperreactive and all, they all go for this bronchospasm, laryngospasm.
Yeah. With relaxation, follicular aspiration would be better, sir. Comfortable.
Yeah.
That's very nice.
No, it's a very good input from Rajesh. As you say, we discussed a few minutes before also that it's a matter of the confidence of an anesthesiologist and relationship with the setup and the fertility specialist. So if the outcomes are good and if the facilities are optimal to our management, so we can choose our own technique. And in fact, probably one more thing we should always be keeping in mind, majority of these patients, they are coming for infertility. So they will have some sort of psychological issues. So they are highly tensed up, anxious.
Yeah, they are reluctant to take spinal anesthetic. Most of
definitely.
them. Yeah.
And some of them definitely bad obstetric history, which we call regularly as even a failed previous IVF, 2 or 3 failed IVF. So see, these are the set of patients which come for IVF subsequently also. So many factors would play a role, including in the decision on type of anesthesia, I suppose. So that's very important. But you are avoiding propofol purely for one episode in Chandigarh.
That is what, sir, like if we have a bad experience, definitely we will avoid.
Yeah.
Teva, sir, the problem with the Teva is we don't have those proper TCI machines, infusion machines. What we do is we either give 20 ml per hour, 30 ml per hour. So we have to titrate it as and when. We can't target it like inhalational agent in this sort of small case. Sometimes we tend to give very less, and it does not help us. And sometimes awareness is there and all, because I give the relaxant. So I I do want my patient to be not aware of things more than anything else.
And also,
So a TIVA was a good procedure, good because no post-operative vomiting. PONV is not there at all with if I use Propofol. I was very happy with that. The problem because of this, yeah, of course, even though one incident is a very serious incident, so we don't want it to, I didn't want to do that. So unless something comes out of it that it's clearly safe for TIVA, I've stopped it. So when was this, sir? This this Chandigarh thing that happened in Chandigarh, some many.
about 1.5 years ago.
So from then on, I stopped because previously I used to regularly give TIVA only, Propofol TIVA. And yeah, I don't know. After that, I stopped because so many companies come. We don't know how, what is because we are going to overdose patients there. So I didn't want, I stopped it from there.
Yeah. But anyways, as Dr. Ravi Shankar has highlighted, the literature nowadays says that there is no great harm in terms of using no harm at all, almost, in terms of using nitrous oxide or
Yes.
per se.
Yes,
because they are all, majority of the evidences are what we call as
no evidence. No, there is no
evidence.
No evidence. Yeah.
No effect. So that way we can feel safe, and even medical legally also we are safe. And practice this patient is comfortable as per your statement.
Yes.
Let us go with that option also, right?
Because it's sevoflurane I'm using. If not, it would be difficult. In any other inhalational agent, we can't use it. So it's very difficult to take a setup. It's as good as your Propofol.
That's interesting. Thanks for the nice input, sir.
Thank you very much.
So, any other question? Okay, sir. So, Ravi Shankar, sir, it has been an excellent presentation and a lively interaction from our participants from across the country. Thank you very much. And the link will be available in the YouTube also. It's already available. And if there is some editing required, that will also be done. And I think very nicely the points have been covered. So on behalf of ISA Ballari and BIMS Anesthesia Alumni Group, thanks for your time and energy for today's program.
Thank you, sir.
Thank you very much.
Thank you, sir.
Thanks to one and all, sir, for participation.